Welcome to the Fight Cancer with Dr. Prasad podcast, your source for the latest, most reliable, and research based information about cancers and their treatments. Hello, I'm your host, Dr. Prasad Raj Dandekar. I'm an oncologist and I head the Radiation Oncology Department at Sir H.N. Reliance Foundation Hospital in Mumbai. Today we have with us Dr. Vanita Noronha, medical oncologist at Tata Memorial Hospital and one of the very few, or I would say the only geriatric oncologist in India. And when I say geriatric oncologist, it's a very, very important topic because geriatric means pertaining to older people. And oncologist, of course, is a doctor who treats cancer. But the important thing here is most of the cancer patients are diagnosed when they are older. And we have only one Dr. Noronha in India who's looking after specifically from geriatric point of view. So welcome, Dr. Noronha.
Thank you so much, Prasad. It's a real honor and a pleasure to be here.
So, Doctor, I'm going to call you Dr. Vanita or Vanita, as
Vanita
we've
is
known each
perfectly
other.
fine, thanks.
We've known each other for far too many years. So, I came across your paper, which you published recently, and which was so interesting. I thought we must have this conversation about shared decision making, which has been the theme of that paper. How should our patients take decision? And it's such an important conversation to have, which is not really discussed openly, neither with the patients nor with the family members. Do you want to give us a little bit of sort of a background of why you decided to do that particular research on geriatric population?
Sure. Thanks, Prasad. So, shared decision making is a very important concept. So, it's really something that we need to be aware of and we need to strive towards for all patients with cancer, but particularly for older patients with cancer. So, what do I mean by shared decision making? So, that means that the decision for any kind of treatment. So, once a patient is diagnosed with cancer, we plan out the treatment. So, first we decide, has the cancer spread or is it localized? If it is localized, what would be the best treatment? Should the patient get radiation or surgery, chemotherapy, immunotherapy? And or if it is not curable, is there a benefit to treat that patient? And if there is a benefit to treating that patient, what is the benefit? What is the magnitude? How much would that benefit the patient? Would the patient live longer with that? Would the patient's symptoms go away? Would the patient's quality of life be better? And and of course, very importantly in our concept, what would be the cost of that treatment? So putting all of these things together, we need to decide this is the course of treatment. And that's what the doctor will discuss with the patient. And then the patient puts their viewpoint to it. So, for example, a person who is a singer, a professional singer, and gets diagnosed with cancer of the voice box or the larynx. So, for that person, so we call it organ preservation. So, maintaining the larynx would be very important. So, that would be a huge point in the shared decision making. So to decide what the patient would best live with. So to my mind, we don't have that kind of data for our patients. And we have a more kind of we call it a paternalistic kind of medicine practice. So we decide and we tell the patient, this is what it is. And the patient goes along with it. But I thought that really is not the right way to do it. And so we try to record what do our patients actually understand? First and foremost, do they want to know? We start with the very first important thing. Do they even want to know if they have cancer or not? If they want to know that they have cancer, do they want to know, how severe it is? Is it, is it life limiting? What is the prognosis? Do they understand the intent of treatment? So when we say intent, we mean, is the cancer curative? Will the cancer will completely go away with our treatment? Or will we be controlling the disease but not completely taking it away? So what is the intent of the treatment? And what are the priorities? So the priorities would be if there is a treatment that is highly toxic, meaning that might lead to a lot of side effects, but there is a potential of cure versus something that is less toxic, a little bit gentler treatment, but does not give them a chance of cure, but gives them a possibility of maintaining their independence, autonomy, quality of life, etc. So what are their priorities? And we sought to understand that through the study.
And that's such an important point. I mean, I see this in my clinic almost practically every day, where we have patients who are so overwhelmed with the diagnosis of cancer. And many patients perceive it that it's a fatal disease, while it is not. I mean, in many patients, we are actually completely curing them. But just the diagnosis itself almost paralyzes them to take the decision. And in India, fortunately, we have a lot of family support. So you have family members, you have sometimes extended family members, the general practitioners, everybody sort of getting in to support the patients. But sometimes I actually feel that that can become a hindrance. And I've seen some examples like that also, that it becomes difficult to manage the family. What has been your experience?
Absolutely. And that was one of the reasons why we did this study as well. So when we started the study, our feeling, and I think the general feeling is that a lot of our patients don't want to know, right? They don't actually want to know the whole details. Many times the family comes in and says, patient doesn't know anything. Patient will completely lose hope. Please, please do not ever even use the word cancer. कुछ नहीं बताना है patient को. Just you couch it in words like कुछ तो operation करेंगे, कुछ तो medicine दे देंगे, not even chemotherapy word. So that's what we actually try to understand. And so through the study, we asked the patient. So I'll just give you a little bit of a little bit more background about the study. So we did this study in our geriatric oncology clinic, which is a clinic in which we do something called a geriatric assessment. So an older patient with cancer has multiple other issues which are not related to the cancer but related to aging. So issues with their function, cognition, the thinking, comorbidity. So other diseases like high blood pressure, diabetes, heart disease. So comorbidities. There are most older people are on multiple medicines. So it's something that we call polypharmacy. So all these medicines interact with our cancer medicines. So social support issues. Sometimes they're staying, an elderly couple staying alone. The kids are in abroad. So multiple issues which are not related to the cancer but impact on their cancer treatment. So in the geriatric oncology clinic, we do something called a geriatric assessment in which we assess all of these different non-oncologic vulnerability domains. So in that clinic, patients come to us after they have everything planned. So they first go to the oncologist, their oncologist. They get discussed within the multidisciplinary group. Then they go back to the oncologist. They get planned for their whatever surgery, radiation, chemotherapy. They get fully counseled. So these patients already have a treatment plan in place. Then they come for the geriatric assessment. So when they came to our clinic, when we did the study, they should all have had already full disclosure of diagnosis, prognosis, understanding of the intent of treatment. So in that, I mean, it sounds a bit absurd, but in our clinic, in the study, we asked them, do you want to know about your diagnosis? So presumably all of them would have already known. But in that, and we still expected that a lot of them would say no, but about 70%, so 7 out of 10 patients said yes, they do want to have full details. Is it that 30% said no? That's not true. Of the 30%, 23% of the family didn't allow us to tell the patient. So the family came in and said, please do not disclose. And we do respect that. I mean, ultimately, the family is the one taking care of the patient and living with the patient. We try to convince the family that, maybe you don't know the patient that well, and maybe the patient would want to make plans, right? But 23% said, please do not tell. And then just about 7%, the remaining 7% did not want to know.
So this is a common story. I mean, I just remembered one patient I saw this week, where he's a businessman working, running his business abroad, gets diagnosed with glioblastoma, a very serious kind of brain tumor, very poor survival, as you know, and they came to us for treatment, and we planned the radiation for them. And both the sons came to me and said, please don't tell my father that he has brain tumor and it has poor survival. So I asked few questions about, this is before I met the patient, and I asked them few questions about what the patient does and everything. And finally, I said, yes, I understand your anxiety of not letting the patient know what he's going through. because you feel that he won't be able to take it. But I said, he is a very wise man, he's educated. Why are you treating him like he's some imbecile? Just the fact that you are in a hospital and you are coming to an oncologist and we are planning radiation, that's enough for him to know that he has cancer, right? Now, if you don't disclose it to him, he's going to be anxious about the diagnosis, and it's like don't ask don't tell, because he can't ask you for the details, and he's going to feel more and more anxious, so it's not fair. And that's exactly what happened when they wheeled in the patient. The first question that person asked me is, doctor, tell me how many days do I have left? And both the sons were shocked, and I just looked at them and I said, you can't treat your family members like this, because they have the right to know and they are smart enough to get this.
But that's absolutely correct. So, I think ultimately the entire onus lies on the patient, right? I mean, so even if the family does not want to disclose, the patient always, at every point in time, has the right to ask the doctor. And if the patient, so whenever the patient says, don't, you know, you oftentimes when the patient comes in with the family and we examine the patient, look at the reports, and then say, okay, I'm going to discuss what our plan is, what your diagnosis is. And I ask the patient, do you want to stay or do you want to go? Because oftentimes the relative says, acha, patient bahar jayega, aap mujhse hi baat kijiye. Then I ask the patient, is this okay with you? Do you really want to leave? And I would say almost 100 times, 10 out of 10 times the patient says, yes, it's okay with me. So I guess at some level, the patient also does not come, that those patients don't really want to know, but you are absolutely right. The patient always has the right to know. So if the patient wants to know, then we have no business, withholding that information, or the family has no business withholding that information.
So, how do you deal with these problems, and what would you advise to our patients as to if they are in a situation where their family members who absolutely love and adore them are not giving them the full information? What should our patients do?
So they have to ask, I guess. So I think it varies from person to person, and this informational need of everybody varies, right? I may want to know every single thing, or for example, I may want to know every single thing about medicine, but I really have no desire to know anything about how the bills are paid for my home, or what who's coming and who's going and who's doing what. So I think that's based upon the person's personality and how, I guess, how optimistic they are, how spiritual they are. There are so many different aspects to that. So if the person really wants to know, they they ask their doctor, and the doctor is absolutely going to tell them. So that's one thing. The catch with that is that all of us in India are very busy, right? I mean, so the time that we have in the clinic to discuss this extensively, the diagnosis and the prognosis, is limited. But particularly in my hospital at Tata, we do have less time because the number of patients is a lot. But I think even in private practice, having extensive discussions and at every visit is probably not possible. So I think one way for them is that there is a whole lot of authentic information on the internet. There is a lot of rubbish information. So that you need to know, to be able to decide what is the authentic information. And there are multiple authentic websites that they can go to that gives a lot of good patient related information. Up to Date has it, NCCN has it. So a lot of patient, it's not the doctor portal, it's the patient portal.
Yeah.
So you can get that information from the internet. There are so many podcasts like your wonderful podcast, but there are multiple other ways that patients can get the right authentic information.
Yeah, and I think patients also need to get that in their head that they have the right to know. It is not a nice thing to happen. They have the right to know. So sometimes I actually flip the question onto the relatives when I feel that, especially in patients where we know that the time is limited. I ask the relatives sometimes that if it was you, would you like to know? And the answer almost always is yes, I would like to know. And then I sort of bring it in because the patient may want to plan.
Mhm.
Patient may want to do some things. Patients may want to say some things to some people. They may have some paperwork left, or they may want to meet somebody or go somewhere, do some pilgrimage or whatever that could be. And I think it is important that we give that authority and autonomy to our patients, to our family members largely, and not keep them in the dark. But things get a little complicated when we have very elderly or very frail patients. So, when you did this study, did you identify some populations where it is more difficult to have this shared communication?
Yes, we did. So there were two things. We tried to figure out which group of patients were there particular groups of patients who did not want to know, more did not want to get the details, and those were women were more likely not to want to know than men. Patients who were illiterate or lower literacy, less educated patients, patients who were sicker. So patients, so we have an ECOG performance status, meaning how up and about the patient is, how active the patient is, or how sick. So if they're confined to bed, if they're sitting down, lying down in bed. So patients who were sicker did not want to know. Um, and patients who had more functional deficits, so more falls, not able to walk properly. So those were the particular groups of patients who did not want to know. So again, the other aspect that we looked at is the patients who had an inaccurate understanding of the intent of treatment. So again, what we had discussed a little bit earlier was when we diagnose a patient, we decide if their treatment is curative or palliative. Curative meaning our treatments are going to get rid of the cancer, and hopefully that patient is going to live as normal a life as if they did not have the cancer. Palliative meaning that cancer is going to be the life limiting factor for that patient. So no matter what treatment we gave that patient, we would only merely be controlling the disease, maybe taking the disease all away for some time, but eventually it would come back, and that would be the life limiting factor for that patient. So, and that was also, to my mind, important, that if the patient knows the intent that they are receiving treatment in is curative or palliative, that all impacts a lot on the decision to receive the treatment. So for example, somebody who's really sick and with other diseases, so maybe advanced lung disease or advanced heart disease, and that person was anyway had another life limiting disease. If they were to be receiving very, very toxic treatment that would prolong life by a little bit, then that perhaps is not the right decision. So they needed to understand what the in what setting the cancer treatment was being delivered. So the similar groups of patients also had an inaccurate understanding of how the cancer treatment was being delivered, curative or palliative. So similarly, women, patients who were illiterate, patients who were sicker, and so those were the groups of patients again who did not have the right understanding. So I think that would go together. They did not, if they did not get disclosure, so they did not want to know, so they didn't get the details. So then they did not understand what kind of setting they were receiving treatment in.
I was surprised, I'm not surprised, but I was disappointed to know that women are more vulnerable. I mean, we know that if we live in the society that we live in, but it's just sad that in today's day and age, women are feeling that they should know less about their diagnosis, which could be potentially fatal or severe than men, and that's something that speaks for our society, and I hope it changes with time. Now, there is always this battle going on between, in patients' head also, there's some confusion about cure of cancer, quality of life, and longevity. And everybody, of course, wants everything.
Mhm.
And it may not be possible that we may not be, it may not be possible for us to offer everything to everyone. What was your finding in this particular study?
Yeah, and so that was the other thing that we set out to find out. what is it that patients prioritize? And we found that there was a stark difference between what patients prioritized if they were receiving cancer in the curative setting versus in the palliative setting. So in the curative setting, 80% of our patients said that they prioritized a cure. So no matter how difficult the treatment is, no matter what kind of toxicity and what kind of long-term side effects, short-term side effects are fine. What type of even long-term side effects, they were willing to accept that for the risk of for the chance of having a cure. So that was 80%. So still, and about 5% said that prolongation of survival. So even if not a cure, then they wanted prolongation of lifespan. But even in that curative setting, 15% of patients said that they prioritized maintenance of independence, autonomy, and quality of life more than a cure. So if the treatment were very toxic, if the treatment led them to lose independence, lose their autonomy, or have a severe decrease in quality of life, they said, we don't want that. We want something that is less aggressive, may not lead to a cure, but would maintain my quality of life. So in the curative setting, 15% of patients said that. Now flip that coin. In the palliative setting, 80% of patients said, you know what, I am not interested in very aggressive treatment. I'm not interested in prolonging my survival, even if what treatment I take, even if it gives me a little bit less survival, but I'm able to maintain my quality of life. I'm able to maintain my lifestyle as it is with good quality of life as an independent person, then I want that. So 80% prioritize quality of life. Um, and about 20% of them said, give me some toxic treatment. It's okay. I do want prolongation of survival.
That's very interesting because the perception that at least I had in my mind, in spite of being in oncology for such a long time, that there is this desire, of course, for the cure, but most people are so focused on longevity that the first question many of these patients ask us, Doctor, how much time do I have?
Mhm.
And maybe this paper is bringing out the nuance in that question that, yes, of course, how much time do I have? But also, then in that time, what quality of life would I get? I think that's the nuance here.
Yeah, no,
One
and
of
the other thing that is important for us to understand is that all the treatments that we are giving our patients have come from evidence that is generated in clinical trials. But in the clinical trials, the primary endpoint is always prolongation of survival. So always overall survival. That's what we call as our gold standard. So hardly any of the studies have actually even reported what effect those treatments have on the quality of life of patients. So that's something that as oncologists we need to understand and be cognizant of, that this is something that is very important for our patients. We need to know what effect our treatments are having on quality of life. I think our field is changing, and hopefully we will change more, but that's something really important.
Yeah. It's like, you are starting a war, but what's going to be the price that you will pay for winning that war? And I
Absolutely.
think both the sides, actually not both the sides, we are also on the same side as our patients are, but we need to be aware of what's the price are we willing to pay, and then take the decisions accordingly. Um, Sometimes we do see patients, relatives coming in and saying, Dr. Saab, do whatever you can for my mother or for my father. I want to try everything that is possible. And at the same time, we know that, okay, this is a palliative patient, we can't really cure them. And the patient sometimes also desires that I want less treatment. And these are again very difficult conversation, that how do we balance between the desire of the patient, what is good for the patient, what does the family want? So as an oncologist, what has been your take on it?
So, I think in the first line and the second line setting, it's perfectly fine that, the benefit is clearly there. Um, Even though the chemotherapy or immunotherapy or, whatever treatment that we are delivering, even though it causes side effects, it's quite clear, I think we know now that despite the side effects, it does improve the patient's condition. So not only prolongs survival, but it lowers the symptoms, right? So if it shrinks the tumor, the symptoms are better, patient feels better. So I think that's relatively clear. What becomes less clear is once the cancer progresses, meaning the cancer is not responding to the treatment, then we change to the next line of treatment, then the cancer progresses again. It's not responding to the standard treatments, and we don't have any kind of standard therapy. There are multiple chemotherapy options that we can try. The benefit is limited. And then again, that is a huge shared decision making with the patient. There are some patients who don't want to give up hope. It's so we explain that the benefit is very small. It may, I mean, there are certainly, all of us have seen those patients who do respond, right? So, and as doctors also, I think as oncologists also, we are eternal optimists. We also, hope, it's hard to give up hope, and you don't want to ever give up hope, right? So there is something, and you tell the patient it's very unlikely that it will work. It will definitely cause side effects. I mean, there are some clear situations that we don't offer, right? So if the patient is bedridden or has a very poor performance status, very huge disease, there are some times that we know that, and that I'm very clear about, and I tell the patient, this I know is going to, if I give you chemotherapy, it's going to harm you, and that's not in your best interest. So rather, I'll give you pain medicine and good palliation rather than the chemotherapy. But the patients who have a preserved performance status, but who have multiply relapse and who really want treatment, so that is it's a difficult conversation. I totally agree with you, and then we have to make an individual decision per patient.
Yeah, and I think having the family on board, um, it's not a very sort of easy conversation, but there are times when I have actually dug deeper and pointed out to the family member that yes, you do want to do everything for your mother, but are you doing that because you want to do that for this particular individual, or do you want to do that because later on, when you look back, you feel I did everything for my mother? And that I feel is a little selfish approach. And it sounds terrible to say that, but maybe it's a selfish approach because you are actually doing it for yourself so that you don't feel the guilt that I didn't do enough for my mother. And then I make them aware that yes, I completely agree with you that you want to do everything for your mother, but the question that you need to ask yourself is this in the best interest of my mother right now? And that's something, is a very difficult, conversation to have. I remember one particular case which it was so unfortunate that I will never forget that we had a patient who had cancer, multiple relapses, and he was really in bad shape. There is unfortunately nothing that we could do for him, and a patient landed up in the hospital. We had to admit him in the ICU, and then as things would turn, he landed up going on the ventilator. By that time, we had discussed with the family that, unfortunately, there is nothing we can offer. We should consider sort of an approach where we let him go and not pursue very aggressively, give a DNR consent and things like that. And it wasn't getting through with the family. And me and my fellow oncologists, my ICU specialist, were really wondering what is happening. There are three sons and four daughters, and they're extended. It's a big family. We have had multiple conversations with them, and there was something amiss. I could feel that there was something holding them back. So I actually caught hold of the older son and I had a one-on-one conversation with him. And what he said was really broke my heart. He said, बाबू ने बहुत पैसा छोड़ा है, 25-30 लाख का बिल नहीं होगा हॉस्पिटल का तो लोग क्या कहेंगे? And I was so shocked with that response. I was like, oh my God, this is beyond what I have ever seen. And then we sort of had another conversation with the whole family. And I said, this is not the right thing to do. You have to let that man go. You can't just hold him back just because you want to prove to the society that you did everything for your father. But that is the unfortunate reality of we as humans. We are flawed, we love, but also we are scared of what will other people say. And sometimes that can be really hurtful to people whom we really love.
I totally agree, but no, I have another story in which I was completely wrong. So this was one patient, older patient, quite old, I think 80 plus, who had advanced lung cancer, had brain, it had spread to the brain. The patient had radiation to the brain, received the targeted treatment. received chemotherapy, was not doing well. So had progressed, was not doing well, and then the patient was brought in by the son, and the patient was was delirious, was not speaking appropriately, came in the wheelchair, and I said, this must be the brain disease must have spread, and so I counseled them. I said, this is from my side, this is best supportive care. This is, we have reached the end. I don't think we can really intervene for this patient. And then the daughter-in-law came in and said, I something has to be done. You have to give something. And I said, no, really, this is not the correct thing. She said, no, is there a treatment available? I said, yes, there will be second line uh, tyrosine kinase inhibitor. But I said, it's not going to help. She said, no, you have to. I'm telling you this. I really want you to do something. So I said, then I have to do blood tests. I don't know, how fit the patient is in terms of blood. Maybe the liver is involved. She said, do whatever. So I said, do you really want me to do blood tests? And, I'm going to be torturing your patient. He said, no, it's not. Do it. So I did the blood test. Turned out that the sodium was 108. And that was the reason that the patient was delirious. So we corrected the sodium. Patient's sensorium improved. We started a TKI and patient actually did well for a few months after that. So I was wrong there. But I think the point that you and I are both trying to make is that ultimately the one important person in that room is, it's not the family, it's not us, it's only the patient. And that patient has the right to decide and do whatever is in their heart. So if they want full treatment, they get the full treatment. If the patient is not able to decide, then their proxy, whoever the next family members, then they have the full right to decide. So I think, and that's, I think, is a message that both you and I want to give, that patients have to decide, and we have to go by what they decide.
Yeah, absolutely. And it's such an important message for everyone that they need to feel empowered. They should not be scared. You are in front of the doctor, just feel free to ask your questions, and take that control in your hand. But Vanita, I want to bring in a little different angle into this conversation now. You have been on both sides of the table now, and
All sides,
you,
right? Yeah.
yeah.
So
So,
I've been a doctor, a patient, and a caregiver as well. So I think
uh,
all three aspects.
so what happened when you sort of became a patient, and that to a cancer patient, and then you are here with us today, rising through that. So what was your experience like?
So I was lucky. My cancer was detected when it was at an early stage. I did have a lot of desire for information. Now, despite being an oncologist and treating patients day in and day out, I still felt that I needed to discuss more, and and look up. So I read a lot, and then that's why I always recommend to my patients, go back and read, because no matter how good and how much time and how much time is spent by oncologists with you, it will not be enough, because the amount of information available is huge now. So I did look up. I did want to know. I wanted to know everything, and there was a test that's not available. So and I was talked out of it. I was said, it's, you really don't need this. Like, so many, everybody else gets treated without that test. I said, no, I if there's any test that helps me to understand my prognosis better, I want it. So I sent the test as well. So, and as I said, that's an individual thing. I felt that I need to know, the only way for me to beat this thing is by knowing it completely 360 degrees. So I did that. I took chemotherapy. I had surgery. I had chemotherapy. I had radiation. I had hormonal treatment, and I'm on targeted treatment. So I think I've had the whole gamut of treatments. But I'm fine. I mean, I think whatever side effects that we talk about from chemotherapy, I think I had that. I lost my hair. I developed damage to my nerves. I had peripheral neuropathy. I had febrile neutropenia, so that infection with a low blood count, nausea, appetite loss, so all of that. But I, it's if you know what is happening, and you know how to deal with it, right? So having knowledge is half the battle won. So, I knew that I was nauseous. I needed to eat. So I would eat every 2 hours, no matter what. So when I had food in my stomach, I felt, I felt better. I had I had fatigue, a lot of fatigue. The first time I felt like, I can't get out of bed. So I went back and I said, what is the treatment for this? It's exercise. You can, how bizarre is that, right? Doing exercise when you're so tired. But I said, so I am gonna walk and I am gonna do exercise. I even tried to run a bit, and I felt better. So it is, I really think that getting information and acting on that information is the best way to combat this illness.
Yeah, and it's your story is so inspirational. You're doing what you're doing for your cancer patients, and then you're going through this journey yourself, and then you're coming out and talking about it. I think that's a very very brave and beautiful thing to do because when as an oncologist, when I tell patients, "Nahi, theek hai, don't worry, there'll be less side effects. It will not be very bad." Some patients have actually told me that, what do you know? You haven't been through this journey. And in your case now, you have actually been through that journey. You did that beautiful video which I saw, and it was so heartwarming to see that video. And I'm going to share that video on this podcast as well as a link so people can see how positive your journey has been and how you have influenced so many patients and inspired so many patients to go through this journey.
Well, thanks,
But
Prasad. And
about
I have to say that the other reason I did the video and the other reason I talk about it openly is that cancer is a stigma. Still, it is a stigma in our society, and a lot of people actually asked me. They said, why are you telling people that you have cancer? I said, I didn't do anything wrong. I mean, it's a disease just like anything else. It's like having high blood pressure. This is not something to hide. It's not a dirty secret that you have, and talking about it is actually very liberating. Otherwise, you have to make up this whole elaborate set. You don't tell something and then you have to have an elaborate set of things to cover it up, which is absolutely not required. I mean, talking about it, you get a lot of support, and there's nothing wrong. I mean, I don't think at least now that I have been speaking about it to a lot of people, it's much better. I'm so glad that I did. So it's really, I think, something that we need to work on. Making it more mainstream rather than talking about it like hush hush. So it's bad cancer.
Yeah, but that's true that, we see that so often that the families don't want to disclose. They will not. Sometimes the patient is almost imprisoned in their home.
Yeah,
They're
yeah.
not allowed to go out because they don't want to, get questioned by other people, especially patients where they lose their hair. It's such a big taboo that, they can't go out to any functions or whatever. And obviously that has an impact on their mental health. Then they start feeling depressed, very anxious about everything. I've had patients where there's no chance of loss of hair, like say, gynecological cancer or patients of breast cancer, where there's no chemotherapy plan. But the first question that they would have is, "Doctor, will I look different? Will there be darkening of my skin and everything?" And when I reassure them that actually nobody will be able to make out that you have cancer, then they heave a sigh of relief that okay, then it's okay, then I can go on with my life. So it's sad, but I think things are getting better, and there's a lot of conversation happening about cancer. And unfortunately, one of the reason is probably because there's such an increase in incidence of cancer, which is very very sad to see, but that's a reality that we live in as of today. From the point of view of information, what you were saying, what I started doing in my practice very early on is I give out all the information, of course, of the side effects that the patients will feel and have, but we also give them all the medications that they may need. So we tell the patients that if you have this particular side effect, please don't wait to come and tell me. Just start this medication, just start this therapy, and of course they have access to us. So if there's anything, they call and find out. But I have found that that actually helps. So from the patient's point of view, what I would suggest is if you're starting a new therapy and you're talking to your doctor, ask them the question that what are the side effects will I have, and ask them that give me medications to take care of that. Don't depend on okay आपको कुछ तकलीफ होगा तो you call me or you come to the clinic sort of thing. Just have that information, the basic, at least the first aid information with you. and then you can connect with your oncologist at a later date for more detailed conversation.
No, that's absolutely perfect. Then that's a really good way to deal with it, and I agree with you. So the thing is that the number of medicines that you can give them is limited, right? I mean, you can't plan for everything. So
Yeah.
if something happens, it's very important to go to either call or to go to the hospital, because sometimes after chemotherapy, something that looks very not so serious, it looks very minor, is actually not minor, right? So if you have a mild temperature, for example, your fever is 99 or 99.6, that's for most of us, that's like a nothing. But if you have had chemotherapy and your blood count is zero, then that's something life threatening. So it's really important for patients to understand that, you know after you when you have cancer and you are on chemotherapy, you have like maybe a couple of loose motions. Don't wait until you require to be on IV fluids. Please come to the hospital and get treated. So I think that's another message that I really want to give out. Please don't ignore side effects.
Yeah, absolutely, because they can become sometimes really life-threatening, and if we take care of them in the beginning, then there's no problem.
Yeah.
So, in today's conversation, we discussed so much about shared decision making, where we have the oncologist, we have the patient, and we have the family members. And while to a viewer it may appear we are thinking about three different sides of the table, I think the way you and I look at it is we are all on the same side of the table, and it's the cancer which is on the other side of the table, and we are trying to tackle the cancer. So, communication, a very, very detailed and trust based communication, I think that's very important between all these three parties is important. The patient needs to trust the family members that they are giving me the right information. The patient and the family member needs to trust the oncologist that they have the best interest in their mind for the patient. And things are getting a little complicated these days because now you have, as you said, first line chemotherapy, second line chemotherapy, third, fourth, fifth. Then you have immunotherapies, then you have targeted therapies, different types of radiation. So the treatment options, even when we are not able to cure the cancer, are are so many. And we sometimes do see patients who come to us where we can clearly see that the treatment that is offered is not really curative, but the patients are confused, and maybe they were given a false hope by somebody, or maybe they heard it as a false hope of cure. And this is also an important thing for us to sort of figure out how to deal with that. We need to break that bad news to the patient that yes, there are options, but the outcome will be this, that the outcome is not going to be, for example, cure in a palliative setting, but it will be, say, pain relief and something, or stopping of the bleeding in some cases. And it's difficult sometimes because the patients also don't want to hear it loud and clear, but it's a balance that as oncologists we have to strike, that we give them the right information, because it's our moral responsibility also, that I don't want to give some treatment to somebody without them knowing what exactly is going to be the outcome of that therapy. So I always encourage my patients that please talk about outcomes, that yes, of course we want to talk about the therapy, but what will happen after that therapy? If you're going to the medical oncologist, please ask them, what is the outcome, what's the final goal, and then you take the decision on that basis. And I think that's something that I would encourage our patients to do, that talk about outcomes, and not just about how and what, but why are we doing it.
Yeah, no, and that was also a surprise to us as part of the study. So we tried to understand if patients understood, what is their expected outcome. And overall, a third of the patients did not understand. So one out of three of the patients who we saw overall did not understand what was the outcome. But then we broke it up into patients being treated with cure as the possible outcome, or palliation as a possible outcome. And among the patients who are receiving treatment with cure as a possible outcome, only about 15% of those patients actually did not understand the intent. But almost, it's like 45 or 46% of patients who were receiving treatment with palliative intent did not know that it was actually with palliative intent. And I think the fault is on both sides. You're absolutely right. Communication is really important. How we couch it. We always, as an oncologist, I'm very happy to tell a patient that you know what, your cancer is going to be cured and you are going to be fine. So that comes out loud and clear, right? So that reflects that the patient completely understands that. Um, in patients who are receiving treatment with palliative intent, it's a difficult conversation saying that we will control your cancer, we will be able to make you feel better. It may not completely go away, and a lot of things do get lost in that discussion. So you're right, we need to work on better communication, and we need to empower our patients to ask if they don't understand that.
Yeah. So thank you very much, Dr. Vanita, for being here with me today, discussing this important conversation, which is never, spoken about for our patients. So thank you very much for being here and sparing your time.
It's been a real pleasure. Thanks so much for having me, Prasad, and thank you for what you're doing. This is wonderful.
Thank you for joining us today. I hope you find today's episode informative. Please feel free to ask your questions in the comment section and we'll get back to you with the correct information. Please do like and subscribe to the channel, but more importantly, share this information with people you care about. Join me in this fight against cancer.